Hey guys, welcome to my channel. We're now going to look at systemic diseases and radiology. I hope this helps you out. If you have any questions, comments, leave them below. Be sure to subscribe to my channel. So let's first look at hypoparathyroidism. There are two types. There's primary and secondary. Um, Sorry this slide is really busy. I try to make everything into a table that's easy to understand. So the primary, basically you're looking at, majority of the time it's adenoma. Um, Minority of the time is hyperplastic glands. The diagnosis is going to be this system B scan, and basically it's you give the patient technetium, and it's administered with a protein. That protein is going to bind to the parathyroid adenoma, and then you get this image and it lights up. So what we're seeing right here is that systemic scan that lights up. Basically, hyperparathyroid, what it means is you have excessive parathyroid hormone, which you end up having increased renal tubular resorption of the calcium, and this is going to increase your production of active vitamin D metabolite, which leads to increased calcium, ultimately leading to hypercalcemia. Basically, it's mainly going to target women that are between the age of 30 and 60 years old. The big clinical feature are stone, bones, groans, and moans. So they kind of rhyme, so it's easy to remember that it's stones, bones, groans, and moans. And I'm going to get more into what I mean by stones, bones, groans, and moans. Um, Treatment, of course, you just remove it. Secondary, on the other hand, it's associated with hypocalcemia, and there are three big reasons. You're not getting enough calcium from the food you're eating. Your body's not absorbing vitamin D, um, and lastly, it's a problem metabolizing vitamin D in the liver or the kidneys. And this is, usually related to end-stage renal disease, where you are going to have enlargement of the jaw, ground glass pattern. So, kind of remember from the differential diagnosis video, or sorry, not the differential diagnosis, the finding video. We talked about what the ground glass pattern means. Features: you can have a brown tumor, and this is very common of it. It's going to be a central giant cell granuloma. Basically, you're going to see this in a patient that's under the age of 30. And then you can also have vascular granulation tissue. Treatment: you want to restrict the dietary phosphate, um, as well as the phosphate binding agent. You can give them calcitriol and cinacalcate. You want to avoid aluminum salts. You can do a parathyroidectomy, and you can do a kidney transplant. So the kidney clinical features of primary hyperthyroidism first is bones. So you'll have osteopenia, osseous changes in the middle and index fingers. So it'll be subperiosteal resorption of the flanges. So if we look right here, we see that there are subperiosteal flanges and generalized loss of lamina dura. So if we look at these images, we can see exactly that. Hmm. So if we look at this image on the left of the skull, what we're seeing is this loss of cortical bone definition. And as I already said, this is the periosteal resorption of the flanges and all the fingers. And then this image right here is basically showing a granular salt and pepper texture that's associated with hyperparathyroidism. Continuation of bones is that you're going to see this brown tumor again. And basically, it could be a unilocular or multilocular lesion. Example of this is right here. We see this brown tumor in the maxilla. You can also see it in the fingers, so where the phalanges are. Typically, the location is going to be the mandible, the clavicle, the ribs, the pelvis. Histologically, it's going to look like a central giant cell granuloma. And in more extreme stages, you can see osteitis fibrosis cystica. And that basically is a cystic degeneration and breakdown of fibrosis within the setting of the brown tumor. Um, in the jaws, you're going to see demineralization, so no lamina dura. So if we look at this, remember the finding we mentioned that you can have a circumcoronal bone resorption where it looks kind of the roots look spiky, and that's exactly what we're seeing here, where we have this loss of lamina dura and thinning of the cortical boundaries, making this root look very spiny. Um, groans, you'll be having abdominal groans where what's happening is patient has duodenal ulcers, which is going to result in increased peptic acid, which is going to be painful. Moans, it's going to be lethargy, confusion, dementia, and then stones, of course, as obvious as it sounds, it's just kidney stones or stones throughout. Hypoparathyroidism, as it sounds, hypo meaning little, you'll have less parathyroid hormone, which means you have decreased serum calcium. And we know calcium is used for muscle contraction. So as a result, your clinical features are going to be tetany of the wrists and ankle joints. This is demonstrated right here. You'll have dry, brittle nails. Some sensory symptoms would be paresthesia of the lips, tongue, fingers, feet, spasm of the facial muscle. To test for hypoparathyroidism, you can simply do a Chvostek sign. If you have positive, it's going to be latent degree of tetany. Basically, the easiest way to see if this works is you're going to go in front of the external auditory meatus, where the facial nerve is. You're going to lightly touch that area. If you see the cheek kind of crinkle towards that or twitch towards the area you're touching, this is going to be a positive sign, so it's going to be indicative of hypoparathyroidism. Long-term considerations are extraskeletal calcifications, renal complications, brain fog, meaning you're kind of not 100% present. It's going to have a reduced quality of life. So if we look at a brain scan of a patient with hypoparathyroidism, you're going to see calcifications of the basal ganglia as well as the paraventricular ganglia. You can have idiopathic hypoparathyroidism, where the result is enamel hypoplasia, failure of eruption. The lab findings, of course, are going to be decreased serum parathyroid hormone, which automatically means decreased calcium, which would mean increased serum phosphate. But the interesting thing is normal renal function. Rocaltrol is a treatment of choice. Pseudohypoparathyroidism. This is where you have normal parathyroid hormone, but the patient is going to come in with hypoparathyroidism symptoms. Clinical features are going to be short stature, obese, short neck, round face, midfacial hypoplasia, mild intellectual disability, short metacarpals, and metatarsals. Lab findings are going to be increased parathyroid, decreased calcium, increased phosphate. Normal renal function. Treatment is calcitriol and calcium. Radiographically, we see that it's calcified basal ganglia and osteoma cutis. So here's just a quick table showing what's going on. So as I said, if you have hyperparathyroidism, increased parathyroid hormone. Hypo would mean decrease. Exception is going to be pseudoparathyroid, where it's normal. In terms of your calcium, it follows the normal trend where hyper is going to be up, hypo is low. The distinguishing for hyper, the primary versus secondary. In the secondary, we have decreased vitamin D. In terms of hypoparathyroidism, we have increased phosphate in your idiopathic and your pseudo. While their normal renal function and drug of choice is for idiopathic rocaltrol, while pseudo is hypoparathyroidism. Sorry, where it's calcitrol and calcium for the pseudo. So hyperpituitarism you have basically two um, outcomes. One is gigantism, the other is acromegaly. Well, if we look at gigantism, what that basically means is you're going to have increased growth hormone, and this is a result of it happening prior to the closure of the epiphyseal plates. And basically, this is where you get like the tallest man in the world because you're going to keep growing as a result of a lot of growth hormone. And this is usually a result of a pituitary adenoma. So a microadenoma is considered less than a centimeter. Macro is going to be greater than a centimeter in size. The result is going to be that you have, um, because your jaw is growing at a faster rate, in terms of the dentition, the patient is going to have diastemas. They're going to have a larger angle of their mandible, and as the body of the mandible and the ramus is going to be much bigger. Macroglossia, and this is the big thing is a class 3 malocclusion, um, or apertognathia. You'll have hypersegmentosis and supereruption of teeth. Basically, to solve this, you want to remove the adenoma. If it's a microadenoma, you can remove it surgically. Macro, it has a 50% success rate with surgery. You can do radiation, but it's not the best choice. Long-term concerns is that since the patient is much bigger, you're going to have a decreased lifespan. Risk for hypertension, peripheral neuropathy, osteoporosis, pulmonary disease. Acromegalia, on the other hand, it's another increase in growth hormone, but the thing is the epiphyseal plates have already closed, and it's kind of a different effect. In this case, it's a gradual progression. So this image on the bottom is a great example where the patient looks completely normal, and then over time, like 10 years later, you see that there's a slow difference. But now we're looking at the big change where her features have become more coarse. Um, she has macroglossia. If we look at her hands, they're much more bigger. Her face is very coarse. Her forehead, her frontal lobe, or frontal bone is very pronounced. Her jaw has become much more pronounced than before. Um, she's gonna have an enlarged sella turcica and enlarged frontal bone. In order to test for acromegalia, you're going to do a serological glucose test, and this is like a common test question. So basically what happens is you give glucose, and if it's a normal patient, the glucose will normally drop off. But in the case of acromegalia, growth hormone does not drop off. Treatment, you're going to surgically remove the adenoma, and you go through the transsphenoidal approach. You can do pharmacotherapy, and of course, radiation is a last resort. Prognosis, they have high mortality, hypertension, coronary arteries disease, increased incidence of diabetes mellitus, and risk for developing colon and thyroid cancers. Hypopituitarism, that basically means you have little growth hormone, and this is going to result in dwarfism. They'll have a hypoplastic mandible and maxilla, and of course, because their jaws are a lot smaller, they're less likely to have third molars developing. Shiitake Higashi syndrome, it's autosomal recessive, mainly seen in kids. Basically, these kids are going to have albinism, um, easy bruising, bleeding, higher risk of infection, neutropenia, impaired chemotaxis, decreased natural killer cell function. There are two types. You have the accelerated and the less severe. The accelerated phase is going to be a lymphohistiocytotic multi-organ infiltration, and this is going to be related to Epstein-Barr virus. The less severe is going to have a poor prognosis, which, makes no sense, but basically, where anytime you have less chance of getting something, it means it's got to be worse. Diagnosis is you look for giant lysosomes in the neutrophils. Basically, you'll have oral lesions, so you're going to have ulcers, hypertrophic gingivitis, severe alveolar destruction, and this is going to result in repeat infections. So if you think about the fact that they have less natural killer cell function, this means that they have less of a defense. Periodontal treatment is not going to be successful. In some cases, you're going to have extensive alveolar bone loss, which leads to loss of teeth. Hypophotophasia, it's autosomal recessive. This is going to be related to the alkaline phosphatase gene defect. It means that you're going to have decreased serum alkaline phosphatase, which means you're going to have increased urine phosphoethanolamine. Um, it's going to be defective skeletal mineralization, demineralization of the calvarian and kneeborns. So if we look at this, we see that the calvarian is demineralized. You have ossification limited to the frontal and occipital bones of the jaw. So there are four main types. There's perinatal, infantile, juvenile, and adult. The perinatal one is going to be the fatal one. You're going to have a premature loss of teeth due to lack of cementogenesis. Basically, what that means is since we have no cementum, periodontal ligament has nothing to attach to, so teeth are going to fall out. Papillon-Lefebvre syndrome, it's autosomal recessive. Basically, you're normal up until the age of 2. Then all of a sudden you get palmar plantar hyperkeratosis, and it's going to be a fetal hyperhidrosis of the feet. By the age of 4, the child is going to lose all their primary teeth. By the age of 14, except for their third molars, they're going to lose all their permanent teeth. So this image right here is an example of this. It's a gingivo-periodontal inflammation with edema, fetid odor, hemorrhage, alveolar bone resorption, and mobility of teeth. You have decreased peripheral blood neutrophil chemotaxis, and the bacteria that's important, Actinobacillus actinomycetomentans, I cannot pronounce that. Treatment is going to be augmentin followed by scropolis, or basically you have to do a lot of oral hygiene and really take care of this patient. Ehlers-Danlos, this is our first autosomal dominant. It's a connective tissue disorder resulting from abnormal collagen. Symptoms are going to be hypermobility of joint, hyperextensibility of skin, easy bruisability. 50% have the ability to touch the tip of their nose with their tongue. That was just an interesting fact. So the types, you got 4 and 7, and these are generalized onset of periodontitis associated with decreased amounts of type 3 collagen. Type 4 is the one you don't want. This is like really severe. Basically, you're going to die young because of dissecting aneurysm or rupture of your aorta. For Ehlers-Danlos, most of these patients are going to have periodontal problems that are going to begin at puberty and lead to the loss of dentition before 30 years old. It sucks. Agranulocytosis, it's a severe decrease in it's a severe neutropenia, meaning that you have less than 500 neutrophils. Ideally, in a normal situation, you're going to have 3,000 to 6,000 neutrophils, so this is a lot less. And it's usually a sign of an underlying issue. So in most cases, it's associated with a drug a patient's taking causing their neutrophil counts to drop. And there's also Esselien-Felty syndrome, which basically sequesters the neutrophil in the spleen. This is also common in Hep A, HIV, EBV, vitamin B12, and folic acid deficiency patients. It's seen in decreased levels of cytokine GCSF, which is in congenitals. Um, well, if you have less neutrophils, of course, that means that you're going to have increased risk of infection, fever, malaise, chills, bone pain, pneumonia, shock. Uh, so the oral lesions that are going to be seen, it's very common. You're going to have basically presentation similar to ANUG, and this is going to be in the buccal mucosa, the tongue, the palate. You're going to have ulcers filled with bacteria and necrosis with sparse host response. Um, Common sites of infection are your lung, your rectum, and your urinary tract. And based on the duration of the agranulocytosis, you can have accelerated bone loss and teeth loss. Um, it's typically secondary to chemo. Then the best choice is, if you know the patient's going to have chemo, give them chlorhexidine as a rinse. So treatment is going to be take the patient off any medication or substitute the medication that's causing this. If it's chemo, you want to you can give them Neulasta prophylactically. For patients with SLE and FETs, you can give them they can have a splenectomy. Quarter of the patients report transient bone pain, easily solved with NSAIDs. Cyclic neutropenia. It's rare. It's isolated hematological disorder having periodic decreases in neutrophils. Causes a third are genetic, which is autosomal dominant. Two-thirds are spontaneous and idiopathic. Symptoms, they're mainly seen in kids. It's periods of infection. Basically, you have low neutrophils, so the kid's going to get sick. It's a 21-day cycle. You want to diagnose with doing a CBC and a differential. Basically, you want to get their CBC every 3 times a week for 4 to 6 weeks. And this is going to allow you to see how the neutrophil counts change within that 21-day cycle. You'll see that the patient has recurrent episodes of fever, anorexia, cervical adenopathy, malaise, pharyngitis, skin abscesses, and oral and mucosal ulcers. And I mean, this all makes sense because they're having these periods of low neutrophils. Treatment is going to be splenectomy and steroids. It has a minor success rate. GCSF is going to decrease the neutrophil cycling from 21 days to 1 day. Some of the dental issues that have been seen are severe perio issues with recessions, tooth mobility, early bone loss. Knowing that this is going to be a risk for these patients, you want to increase the frequency of hygiene visits, so more frequent recalls. You want to give routine dental treatments confined with basically, sorry, let me rephrase this. If the patient is going to have some big dental treatment, you want to monitor their neutrophils toward the day that the neutrophil count is greater than 2,000 to ensure that they're going to be successful. Leukemia. So you have factors increasing the incidence of leukemia. It's going to be like Downs, Fanconi, and Klinefelter syndromes. And these are going to be or exposure to benzene or chloramphenicol radiation exposure. T-cell leukemia viruses 1 and 2. Symptoms is going to be pallor, shortness of breath, fatigue, petechiae, ecchymosis, spontaneous gingival hemorrhage, epistaxis, and excessive menstrual bleeding. Childhood leukemia is this image right up here, and it's associated with hypertrophic gingivitis. Adulthood is where you have hypertrophic interdental papilla. So if we look at the interdental papilla, it's very hypertrophic. And then we have hemangiomas on the lower lip. You can have neutropenic ulcers that are deep punched out lesions with gray-white necrotic bases. Acrodynia, remember, this is mercury related. So if you remember, Diana likes mercury or Diana's kids like mercury. Just remember Diana at the end, kids, and mercury. And what happens is you have basically excessive salivation, metallic taste, ulcerative gingivostomatitis with inflammation. There's going to be enlarged salivary glands, gingiva, and tongue. Gingival Gingiva may have blue-black lines along the free gingival margin. So what we see right here. Um, Bacteria are going to act on the medical. They're going to basically eat the metal particles, generating mercuric sulfide, and it's going to destroy the alveolar bone, which leads to tooth loss. If it's exposure in kids, it's going to be Pink's disease. So kind of look at his hand. Basically, these kids are known for tearing out patches of their hair, so that's what we're seeing right here. Some of the symptoms are cold, clammy, bright pink coloration uh, on the uh, pink coloration, peeling of the hands, feet, nose, and lips, pruritic rash, severe sweating, increased lacrimation, irritability, insomnia, photophobia, excessive bruxism, um, Arturia. It's going to be associated with silver, and just remember, basically the patient looks silver. That's what we're seeing. This senator right here and this girl right here, and it's basically pigment accumulates in sun-exposed area along with hair, fingernails, and oral mucosa. Nasal inhalation of silver salt ends up leaving deposits on the palatal mucosa, as we see right here. So, Argyria, silver. Acrodynia is mercury. So remember, Diana's kids like mercury. And if you think of a gyrating roller coaster is made out of silver, it's a bad one, but let's go with it. Lead poisoning. Basically, the big thing about this is you're going to see a blue-black line along the pharyngeal margin. And this is known as a lead line. So what we see right here, bismuth poisoning is depositing at the gingival margin. It's associated with anti-syphilitics, and bismuth is no longer used in syphilis medicine, but in the old days. Well, I hope you liked the videos. If you have any questions, comments, leave them below. Please give me a thumbs up and subscribe to my channel.